sure you all know Keith Hill, but just in case you don't, he's a top international researcher. He's secured over $9 million in grant funding for research projects, and his interests include falls prevention, gait, balance assessment and interventions, healthy ageing, stroke and hip fracture, rehabilitation and resident care. And he now has 135 publications, which is pretty awesome. So, over to you.
Thanks, Sue. Can you hear me up the back? Yeah. Alrighty. I'm not sure who wasn't here when I spoke last year. It seems like only yesterday. It was August, I think. Well, most of you. Okay. Well, last year I gave a fairly general overview of falls prevention in hospitals. This time I'm looking a bit more specifically at research, and particularly high-level research. So what I was going to say is I hope that a bit of it's not duplicative for those of you who are here, but since most of you weren't, it won't be. Just very briefly in terms of background, falls prevention in hospitals is a major problem. It's been recognised, and we've had projects and funding and an emphasis in clinical practice for probably 10, 15 years now that this is a major problem and resources going into it. Nonetheless, this problem hasn't gone away. In fact, it's probably getting worse now than it was 10 or 15 years ago. A bit of that's around the complexity and the ageing of the populations that we're seeing. And I also do believe that this is the hardest area of falls prevention. If we think about falls prevention in the community, falls prevention in residential care, falls prevention in hospital, we've got tons of research, over 150 randomised trials in the community setting, far fewer in residential care and far fewer still in hospitals. So I think that is also a reflection of how hard it is to do research and practice in terms of reducing falls in hospitals. Nonetheless, we are getting some research evidence now that we can impact on falls, so that's pleasing. And probably the other thing I want to emphasise in terms of background is that the people we're seeing who are coming into hospitals have a range of chronic risk factors for falls, so they have a certain level of falls risk. But the reason they're coming into hospitals is because of an acute health problem. Now that might only be something fairly simple like a UTI or a chest infection, but any acute health problem superimposed on the chronic risk factors for falls magnifies that person's risk. So they are far more at risk of falling while that acute health problem is evident. So we need to keep that in mind and change our mindset from what their risk was before they came into what it is now. Some of the challenges in hospital settings are around the very short length of stay you often have, so you don't have luxury of getting to know these patients really well. Subacute, you've got far better chance of doing that. Staff variability, rapid change in health status, often improving but also sometimes rapidly deteriorating and worsening falls risk. So all of those things make this a very challenging area. So what I'm going to focus on here is the Cochrane review. I envisage that the majority of you will be familiar with Cochrane to a degree, but I will do just a very brief orientation to it as well for those who may not be, just so that we're all on the same page. In terms of reviews of literature, this is one of the best forms, the best places to go. The Cochrane reviews are freely available. They're very lengthy. The one on hospital and residential care for falls is about 150 pages. But there are summary statements if you don't want to plough through that. But there's a lot of other useful information in there if you do want to plough through it. But the reason it is very good is it's very systematic, very comprehensive in terms of its review. It catches everything that's out there, and it only includes very high-level quality studies in terms of randomised controlled trials. So you can pick up published articles on falls prevention in hospital, many of them not randomised controlled trials, many of them with a lot of potential flaws that mean that you can't take them that strongly in terms of what their findings are. They might be useful to a degree, but there's usually potential confounders that influence what the result was, so you need to keep that in mind. So randomised controlled trials are the thing that you can have most confidence in from a research perspective. They also use very rigorous searching strategies, independent reviewers, so several people looking at each paper and reviewing them, they have a quality rating. Even randomised controlled trials, you can have good and bad ones, and so they independently rate the quality of these trials and tell you what those are. So again, you can decide which one of these randomised controlled trials to take a bit more focus on. And the other really good thing is they provide a meta-analysis where possible, so that instead of you looking at the area of, say, exercise in falls prevention, coming across 5 articles, 3 of them say it doesn't work, 2 of them say it does, but what do you do with all of that? The beauty of a meta-analysis, so long as you've got roughly similar intervention and a similar outcome, is you can put those 5 studies together and say, overall, this shows me that it does or it doesn't work. Okay, so that's a really nice thing around systematic reviews, meta-analyses like the Cochrane reviews. So there are a whole range of different types of studies you'll see, and this is a hierarchy in terms of research evidence. At the top is the meta-analysis and systematic review. So that's what a Cochrane review is, so that is extremely strong evidence. The next level down is where there's at least one properly conducted randomised controlled trial. So there's now a growing number of those in the hospital setting for falls, so we've got a bit of a basis there. Below that you'll see quite a range of different types of studies. We might have pre-post studies where we look at what was happening in our ward for 3 months and then we introduce a change and we look at what happens in the next 3 months. That's a lower level of evidence. We might still get some good findings from that. And I will actually be talking to you at the end today about a couple of bits of work that I've been involved in that are at that sort of level. So they're not randomised controlled trial, they're not totally conclusive, but they do add to what we know. So all of those are useful forms of research to have happening, but you just need to realise the limitations of them. So just in terms of orienting you, because I will be showing several of these plots throughout the talk, these are the summaries of that are in each main type of intervention in the Cochrane review. So just to walk you through what you see here, I'll actually move away from the microphone because I can't see the left. Well, actually, I might have to stay. No, I'll move away and just point on the slide. So what you have here, this is looking at multifactorial interventions in hospitals and looking at the outcome of rate of falls. So there are 4 different studies here which have been identified looking at that outcome with, and that intervention. So each line there is a separate intervention or a separate study, sorry. This is one study, this is another. The next thing to look at is that there is a thing called a line of unity down the middle, and on one side you've got favours intervention, so anything on this side here is positive from a falls prevention point of view. Anything on this side is negative. It actually increases the risk of falls. And there are a couple of studies, particularly in residential care, that have actually increased risk of falls. It can happen with high-risk patients, so we need to look at that. But generally, most of them are somewhere on this side. For each of these studies, there's a summary statement. The little red box here shows what the average effect of that intervention was. And then there's a set of whiskers that go through that little red box, and they're the 95% confidence intervals. And if they cross this line of unity, that means it's not statistically significant. It showed a trend, so this one is in the right direction, but it's not statistically significant. This one is in the right direction, doesn't cross the line of unity, it is statistically significant. So it did reduce the rate of falls, okay? And the next thing to look at is the bottom of any of these plots. It has a diamond which summarises for all of these studies here what was the overall effect. So if that diamond touches that line of unity, it's not statistically significant. If, like in this case, it's on the left-hand side and doesn't touch that line, it is statistically significant. So you can say, just having a quick eyeball at this, that over the studies that have looked at multifactorial interventions in hospitals to reduce rate of falls is a significantly positive intervention to do. You will have a good chance of reducing falls. If that diamond was in the middle, no effect. if it's on completely on this side, you've got a problem. If it's on the line in the middle, doesn't mean that an intervention won't work. It just means that the trials that have been conducted haven't shown an effect. And what you do gain with meta-analyses, you also lose a little bit of detail. These are broad multifactorial interventions. Each one's somewhat different. So you still have to go back to the individual studies to get detail about the method. So there was a Cochrane review that they have lumped hospitals and residential care together. Prior to 2010, the earlier ones actually put all falls prevention together, community, hospital and falls. In 2010, community was separated because it is quite a different area and there was so much in that setting itself. And in 2012, the review's been repeated. A couple of things to note in terms of the change. In only 2 years, in 2010 we only had 11 studies. I said 150 odd in community. We've got 11 studies in hospitals with around 7,000 participants. So it's pretty low level in terms of when you think about the different types of interventions that could be evaluated and so on. In 2012, 2 years later, we've had about a 50% increase in the number of randomised trials. So that's really pleasing. There's a lot of things happening. What I talked to you about today is going to be different in 12 or 18 months' time. We're on a bit of a growth spurt with studies. The other thing to note is the number of patients in these studies. They have got larger and that gives you better confidence in the results as well. So we've gone from 7,000 to 29,000 patients in that 2-year period. The new studies that have been added, just to give you a little bit of a flavour, there's 6 new studies. They've looked at low beds, guidelines and education to reduce adverse events generally. So falls was one of the adverse events that they were looking at, but not the only one. Several multifactorial interventions, which I'll elaborate on in a little bit. A falls prevention toolkit, which used some IT support around decision making. And a patient education approach. So some fairly diverse approaches have been evaluated in the last couple of years, and so it is worth coming to tell you what is new. So I'm just going to go through some of the main areas and show you some of the findings from the Cochrane review that was just published. Exercise is the first one I'll touch on. The first thing to note here is only 2 studies. And the other thing I didn't point out, but the N there, which is highlighted in red, is the number of subjects. And these are very small studies, and as a general rule, I'd say it would largely be by chance if you happen to get a reduction in falls in this size sample. So they are very small, 30 subjects and 14 subjects in the intervention group, 24 and 15 in the usual care. But, surprisingly, these 2 studies, neither of them by themselves were statistically significant, because you'll see the whiskers do cross that line of unity. But if you look at the diamond at the bottom, it is statistically significant. So this is where the pooling of data does become useful. So it's just on the left-hand side of that line of unity. So it suggests fairly strongly, I'd still like to see a decent-sized study in this area, but it gives pretty good support that exercise above usual care, above whatever is involved in usual exercise in wards, is a positive effect on reducing falls. But one of the things I was just mentioning was the diversity of the studies, and this isn't reflected if you just look at this summary statement. These 2 studies had quite different types of interventions, even though they were both exercise. In the community setting, by and large, the recommendations are that an exercise program has to have a balance component to it if it's going to reduce falls. There's a lot of other benefits of strength training and walking programs and all of that, but if it doesn't have a balance focus, it's fairly unlikely to reduce falls. And if you look at this, the first study there, it had 2 by 30-minute daily sessions, supervised strengthening exercises, okay, purely focusing on strengthening, not individually tailored, which is another issue from an exercise point of view. It was a generic program, physio-delivered, and the control was just usual physiotherapy. The other study had compared 2 different dosages of a program, 10 sessions a week to 3 sessions a week, and the program included balance and gait exercises, lower limb exercises and stretching. And that's a bit more along the lines of what I would have thought from the research we've got, particularly in the community setting, that might be more likely to reduce falls. But what I'm saying is, if you read this and you say exercise is good, well, what type of exercise do you do? Because we've got 2 different types here, and neither of them by themselves were statistically significant. So we really do need a bit more research in this space to say what is it around a type of exercise in a hospital that is going to be useful. Vitamin D supplementation, there's only one study. Many of our patients are vitamin D deficient, particularly our older patients, and so this is an important area. I would have thought this is not particularly something from a hospital inpatient perspective to be too worried about, other than perhaps identifying and instituting supplementation if a problem's identified, but I wouldn't have thought there'd be much likelihood of change in the intervention, in the hospitalisation period or shortly after. You usually need a bit longer. But one study was conducted, didn't show a statistical significant result. This one is just looking at environmental interventions versus usual care, and these are quite diverse. The first one actually doesn't compare to a control, but it actually compared 2 different types of flooring. And so it compared vinyl flooring to carpet flooring, and they did find a significant reduction in the vinyl flooring area. Floor surfaces have got a whole range of issues around them in terms of slipperiness versus not slipperiness if they get wet, infection control, foot clearance for patients who have got poor foot clearance. Carpet's going to be more problematic. So I don't think there's really strong evidence, and this again was a very small study, so I'd probably take this with a grain of salt. But it is an important consideration if you're looking at new facilities in particular. There's also issues that these haven't explored, and that's around the impact if you do have a fall and reducing injuries. And there's very little on injury reduction in these studies. But if you've got a bit more of a compliant floor surface, and people have thought about, particularly in residential care, looking at floors like a basketball stadium floor that has a bit of give, that might actually reduce the impact on the hip and perhaps reduce hip fractures. So this is an area that still needs quite a bit of work, but I think the jury's still out a bit there. The other studies there in terms of environment really haven't shown any effect. I still think the environment's critical, and I do think that hospital environments are dreadful generally, no matter what people say, no matter how new the hospital might be. Looking at multifactorial interventions, and this is probably the most explored area and probably the most positive area in the hospital setting. One of the studies looked at what they call a falls prevention toolkit, which was IT software and support, decision support, risk assessment, nurse decision-making support, and so on. So this was a trial in 4 fairly large hospitals, had 10,000 patients, so a big study. They designed this software themselves. What I couldn't get from the study written up was how the IT was actually used, whether it was PDAs at the bedside or desktop computers in the nursing station. But what it did do, it had a risk assessment tool linked to it. You filled in the risk assessment tool. It gave some suggestions with respect to interventions. It printed out bedside posters about risk. It gave a targeted intervention, education brochure related to the risk factors that were identified for the patient, and developed a care plan all based on that computerised risk assessment. So it's taken risk assessment a little bit further than what a lot of the studies have. And it did find significantly less fallers in the intervention group and a lower falls rate, around about 25% reduction. It did look at falls-related injuries, but there was no significant effect on that. This is very poor. I just tried to take a shot of the from the paper, but this is the template of the risk assessment side down the left side, and some of the interventions on the right side, and then linking up to printing posters and printing education information. Not sure if this is commercially available. I got the sense that it was something that the authors were working towards, if it's not already. I'll come back to multifactorial interventions in a minute. The next one here is knowledge and education. Knowledge and education, and with several of these other types of intervention types as well, it's sometimes a little difficult to classify exactly what it is. And so the studies can sometimes fit into other areas, and I'll show you that I've actually put a couple of education approaches that actually are a little bit tailored to what the individual is like and what they do, that I would suggest could be considered multifactorial rather than just education. But overall, this suggests education is not terribly effective. In terms of back to multifactorial, I'm sorry I'm chopping and changing a little bit between education and multifactorial. I'll come back to an education one in just a minute. But this was a study done in an acute hospital in Singapore, fairly large study. They used, there's probably at least half a dozen to 10 different risk assessment tools that have been validated in various acute or subacute settings. Hendrix is one of those that's been around for a while. They used that as their identifier of risk, and so they only included in this study patients who had fairly high risk of fall, so it wasn't everybody who came in the ward. The intervention had some education that was for patients. Actually, it's called a multifactorial intervention in Cochrane, but it was really a single education session for the patient with the nurse researcher. It was only 30-minute maximum session, but it was tailored to the individual. They did include the relative if the patient was confused. But it was really what came out of that in terms of multifactorial interventions, which is why I think it's been classified in that way. And this fairly simple approach did actually reduce the risk of falling substantially. I think in the previous session I talked a little bit about a local study, Terry Haynes and also Anne-Marie Hill from here. This study involved a number of hospitals in Queensland and Perth, which looked at two different types of education. One was providing a DVD of information about general falls risk in hospitals. So it was really targeted to things like make sure if the nurse is leaving you that the call bell is in reach, make sure if you need to go to the toilet that you allow plenty of time to ring the call bell, those sort of things, rather than more generic falls risk management advice. And so it had the DVD, and then it had a second arm which had the DVD plus a session with a health professional one-on-one talking about that patient's individual risk factors and what they should think about in terms of their own risk management in the hospital. So it was a bit more tailoring rather than a generic education program. If you look at the overall results, which come up in a couple of the slides coming up, there was no overall effect in this study for all the patients. But one of the very good things about this study was it did include patients with cognitive impairment, which a number of the other studies don't. And we need to recognise that increasingly a reasonably high proportion of the older people in your wards do have either a transient or a permanent cognitive impairment, and that's going to impact on their falls risk. And so we do need studies that include that group. And when this study sub-analysed as to whether the patient was cognitively intact or cognitively impaired, the cognitively intact patients had a significant reduction in falls. The cognitively impaired patients actually had an increase in falls injuries. So it's interesting in those couple of different ways, but in particular that we might need to think about cognitively impaired patients in a different way to what we do with our cognitively intact patients, and that hasn't been the approach to date. And that education probably may need to be something that you use very judiciously and perhaps target carers and nursing staff rather than patient for cognitively impaired patients. But the evidence in this study was fairly strong for cognitively intact older patients reducing falls in hospitals. So the summary of multifactorial interventions here is there's these 4 studies, and this is the one that I showed you right at the start and tried to explain. So clearly across these 4 studies there is an effect of multifactorial interventions. A number of them are based on a risk assessment and then tailoring interventions. The important thing with risk assessments is that they are used and that they are used to inform interventions. It's no good just doing the checklist, filing it away and perhaps acknowledging that the person has high risk. The value is really in what you do to address the individual's risk factors. So that slide was with the outcome of rate of falls, and there's several different outcomes. The next one is on number of fallers. So this didn't quite reduce the number of fallers, but it was certainly well in the right direction. The previous slide shows that the multifactorial interventions did reduce the rate of falls. This is where I come to the issue that, again, a multifactorial program can be quite different, and often programs select a limited number of interventions to put in place. The common element across all of these, and the 2 on this side could be broadly considered patient education. The other 4 were more general multifactorial, where there was a range of things put in place as well as education from the Haynes study. But you can see that there's quite a few different types of interventions that these studies have put in place. So the question for you is, well, how do you distill this? Which tool do you use? And which interventions do you put in place? And there is some evidence now suggesting that perhaps trying to address too many risk factors might be problematic. So you might not want to try to do a very detailed risk assessment and have 13 different risk factors that you've got to try to address. That's probably a bit too much for you and for the patient. And so one of the studies that I'll touch on a little bit later on has selected 6 fairly low resource interventions that they have as a suite of any one of the 6 could be put in place, or a combination of, for a patient at high falls risk. And so that reducing the magnitude of things seems to have a bit more of an effect on adherence and compliance by nursing staff, other staff, and feasibility and sustainability. So keep that in mind. What this tells you is we really don't know. The only one probably to ignore a little bit is the orange one. This I haven't focused on in this talk because it's not in the most recent 2 years. But this was a very big study, had about 4,000 patients, if I remember correctly, in Sydney hospitals, and it had absolutely no effect. And so that's one of the things perhaps to keep in mind, and they perhaps had nearly the biggest number of things. But I think one of the problems with this was they tried to come into wards with an external team, do some things on the wards and then leave. And there probably wasn't enough around culture change and in there for the long haul. And that's what I would take from reading this study as to why it might not have had an effect, even though some of the interventions were probably appropriate and might have helped if there was a bit more around engagement and sustainability in the way it was implemented. So from all of this, I think we can say risk assessment does seem to be useful. Still a little bit of greyness about what risk assessment, but some of the things are around it's got to be acceptable to staff. There are a lot of hospitals where there's risk assessment tools that somebody's found that have been put in place. The staff don't like them. They classify everyone as high falls risk, so the staff don't use them, and they're not used to guide interventions. So if that's the case, it's a waste of everyone's time. You need a tool that is reasonably evidence-based, hopefully something that has had some research done on it that shows that it's reasonably useful in some of those areas, and that is acceptable to staff. So that's really the snapshot of the new research in the Cochrane review. What I want to go through now for a little bit is talking about some work that a physiotherapist at Ballarat Health Services, Anna Wong-Shi, has been doing with me through La Trobe University for her PhD, and she's about to submit her PhD in about 2 months. So this is work that has come from being on the ground in a health service. It's subacute, so you need to keep that in mind if you're thinking particularly acute. But I think there's particularly some useful findings, and also a useful way to think that with her work she didn't have a large project grant of funding. She had no real funding at all. What she did was cobble together resources within her health service and her own time in studying for her PhD. So that's another thing that I think to reinforce is that you can do some useful small-scale things. They're not the big randomised trial. They probably won't ever get into a Cochrane review, but they might be as useful or more useful in some ways. Hopefully no one gets to see that video and broadcast everywhere, but because randomised controlled trials are held up as the gold standard, but there are often a lot of issues around the way you have to run the rigour of a randomised controlled trial and these meta-analyses where you lose a lot of the detail. Sometimes some of the detail in a small study can be very useful for you. So hopefully you might think about a few projects you might want to do here. So what Anna did, she wanted to look at what is the current state of play in falls prevention in this subacute hospital setting, and then look at a couple of interventions. I'm not going to go through the baseline review other than to say that it looked at their falls rates, and falls rates in this subacute hospital were very high compared to what's been published for subacute hospitals. They also looked at their existing risk assessment tool, which had been in use for I think about 7 or 8 years, had no research, no validation, and staff didn't like it. So she wanted to explore a bit around that tool. She found that it had low predictive ability. Staff weren't using it to reassess after a fall, which is what one of the recommendations in terms of best practice guidelines. If a patient falls, do a reassessment because some things can change. And she also found that there was very limited targeting of falls prevention strategies. So even if a risk was identified, there was not often an intervention or two put in place to minimise the risk. So it was really a waste of staff's time doing this. And it's surprising that it's gone on for quite a while, but this is what happens in many hospitals. Something gets adopted and then it doesn't change and no one evaluates it. So she then went on to what she called a documentation trial, and what she wanted to do was look for a different risk assessment tool and try to implement that, and she looked around at what was there, and she selected a thing called the Northern Health Stratify. Now this is a tool that was developed at Northern Health in Victoria, must be around 10 years ago, and they introduced it and a small suite of interventions. This is the one that I talked about that chose to limit the amount of interventions that they wanted to put in place, but try to get high buy-in in terms of those interventions being implemented. And that total package, it was introduced and it was also part of a nursing care plan. The risk assessment had to be ticked off at the end of every shift. It was part of the nursing care plan in terms of what the patient's risk is now and and what are the interventions. So it did require a bit of extra documentation, but it really focused people on falls risk, and that's a bit different to most of the other programs. The falls risk assessment's often done, filed away, and doesn't actually get re-looked at unless there's a fall, and even then it doesn't always happen. So the other thing why she chose Northern Health Stratify, it was based on local knowledge on some work that was done at Northern Health, which is an acute hospital, and nobody's looked at this in terms of its usefulness in a subacute, and there are some reasons why some tools may not work across both. But it was also used, that suite of things has been in place now for quite a long period at Northern Health, and they've looked at every year what their falls and injury rates are. And they've published this work over about a 9-year period, and it's actually been a substantial reduction in falls injuries across Northern Health. So that's a very major outcome from the perspective of a fairly small intervention. So she felt that there was enough there to say, let's try this out in the subacute setting. So she wanted to compare the old tool, the BHS FRAT, with the new tool. She wanted to look at the predictive accuracy, whether either tool very useful in saying you're a high risk of falls or you're not, and also wanted to look at the ability to target falls prevention strategies, how much the tool guided and that actually resulted in interventions being put in place. This is the tool. It has 9 items on it, all fairly quick and easy to score, and it has a couple of interventions against each one which you can choose none, 1 or 2 of, depending on how many there are. So the actual interventions, this package is called the 6-pack suite of interventions. One is just a falls risk alert sign for those patients who are at high risk. So it's just alerting everybody around the patient that if it's not your patient and you see them starting to get up, perhaps you should come and do something to help them. Supervision of patients while in the bathroom should be fairly standard practice for high-risk people, but it's not always the case, so that was another intervention. Use of low beds for high-risk patients, ensuring the patient's walking aid is within reach, establishing a toileting regime. Incontinence is a major contributor to falls risk in hospitals, and use of a bed chair alarm when the patient is in the bed or chair, and that was limited by the number of bed chair alarms, but priority was given to those with high risk and recent falls. And this is the care plan, which just shows the ability to repeatedly reassess. Very briefly, what the results showed that in terms of the tool being used on admission, both tools were almost completely, for all patients, done within 24 hours, so that was good. In terms of reassessment after a fall, the TNH Stratify getting up towards 2/3. BHS FRAC was not triggering reassessment at all, and that's a major problem. Sensitivity and specificity are measures of predictive accuracy, and ideally you would want both of those to be around about 0.7 or more for a tool to be good at classifying you're at high risk, you're not. And the sensitivity for both of these tools was good, which is how accurately you can predict who's going to fall, but the accuracy of predicting those who are not going to fall was quite poor. And so you really need both of those. And so in terms of prediction of fallers and non-fallers, neither of these tools was great. In fact, just about all of the studies that have been done on risk assessment tools in hospitals have been fairly limited and poor with respect to their prediction accuracy. And I'd argue that it's because of the short time of people being in hospital that saying you're going to fall or you're not going to fall, some of these patients will fall the next day after they go home. It's just something that's going to happen, but we're only looking at them for a very short time. So the prediction ability of these tools is fairly limited, whereas often we look at using a 6-month or a 12-month period at home for a prediction accuracy of a tool. There were 3 common types of risk factors: cognitive impairment, incontinence, and mobility impairment that were common across the 2 tools. And you can see substantially higher rates of interventions being put in place with the TNH Stratify than with the BHS FRAC. So again, it was guiding interventions a lot more. So by and large, this suggested that the TNH Stratify tool was a substantially better tool and much more acceptable for staff than was the original tool, and so it's been accepted as normal practice in these units now. And there is a very large randomised controlled trial underway looking at this suite, this risk assessment tool and this 6-pack program in acute hospitals in a number of hospitals on the East Coast. This study is going to have 26,000 patients, and it's about 3/4 of the way through. It's well on track. So I think this will give us really good evidence around this type of intervention. At the moment, we've only got that longitudinal study, which is not at the level of a randomised trial, but hopefully this will give us good support for this tool and the suite of interventions that are associated with us. So another thing that came out of the baseline audit was what were the most common risk factors, and a couple of the big ones in the subacute setting, which I think apply pretty well to acute hospitals as well, is cognitive impairment and use of psychotropic medications. And so with Anna's subsequent study, she focused on the cognitive impairment area. she also found, in terms of that her first bit of work, that there was fairly poor implementation of strategies for people with cognitive impairment. So she looked at two interventions. One was a bed exit alarm, one was a volunteer pilot. So cognitive impairment is a common problem for your older patients. It is associated with an increased risk of more severe injury. Given the same level of frailty, cognitive impairment will magnify the likelihood of a severe injury. People with cognitive impairment are often excluded from the studies that we do have conducted, and so this is a group, even though it's a growing proportion of your clients in hospitals, that we don't have good research on. So these were all factors around why she felt she wanted to target this fairly difficult area. So she wanted to evaluate an electronic sensor alarm. The wards have been using a floor sensor mat, so that triggered when a patient got out of bed. Some would argue that that's already a bit too late, and there are also issues around potentially tripping hazards and so on with floor mats. So she wanted to test the usefulness of the alarm and in terms of falls and also staff satisfaction. So she looked at a several-month project. There were three 21-day phases where the alarm was not in place, and then it was in place, then it was removed again. And the inclusion criteria were having cognitive impairment, having a high falls risk, one or more falls in the previous 21 days. So these are really high-risk patients, having incontinence and requiring staff assistance for mobility or supervision for mobility. And the short of that, in terms of reducing falls, there was a significant reduction from that in pre-intervention phase, where the person didn't have the bed alarm sensor, to the intervention phase when they did have the bed alarm sensor. The rate of the incidence density did go up after the intervention when we took the bed alarm away again. Didn't reach statistical significance at that point, but it was certainly going in the wrong direction again. So this does provide some support that the use of the bed alarm did help to reduce falls. There are problems with all bed alarms, and in particular the false positives is an issue from a nursing staff perspective. They don't want to be getting called to rush into the patient a lot of times when the patient's just moving a little bit and then they don't get out of bed. Staff can become a little bit desensitised if that's the case. But there were a majority of true positives, so in over half of the instances the patient was getting out of bed, and so that's a reasonably good result. There were a reasonable proportion of false positives, but the staff did recognise that in a number of these instances they felt that the buzzing of the alarm actually stopped the patient from moving. So the patient was starting to get up and the alarm sounds and they decide to go back. So that in itself is not a bad false positive. Staff feedback was generally quite positive around the tool, around the use of the mats. The main downside was that in one or two instances the mats did seem to move a bit down the bed and become a little bit out of the ideal position, but that was only in rare occasions and something that we need to think about and perhaps check on a regular basis. So overall, this did seem to be a useful approach. I'm not sure how much you use bed sensors, and in terms of randomised trials, there's only been one that's been conducted. It was a fairly small study and it didn't show a significant result. So at this stage, we don't have really strong evidence around bed chair alarms, but this I think helps a little bit to say it's probably worth the investment, or at least trialling with some of your high-risk patients. The other intervention that was trialled was a volunteer diversional therapy pilot, and again this was looking at patients with cognitive impairment and the recognition that a lot of the falls that happened with this group are often unwitnessed, so patients by themselves for a period of time and perhaps doing things partly because of boredom or nothing else to do, and they're getting up when perhaps they shouldn't be getting up. So the aim was to look at a volunteer program where a volunteer spent some time with at-risk patients and to see whether that had an effect on falls, and also just to check in terms of acceptability for patients, carers and staff and volunteers. So again, the inclusion criteria were pretty high risk, low and mini mental state examination scores, so cognitively impaired, diagnosis of dementia, and priority given to patients who have had a fall already during their hospital admission. There was some training involved for the volunteers. They had to first of all develop a bit of a network of volunteers. They had some volunteers within the hospital setting, but this was adding to that and adding a new set of tasks. And so the training was required, and that was provided by a clinical nurse consultant and a diversional therapist. And primarily the volunteer was to spend some time with these at-risk patients, undertaking some reorientation type of activities and some diversional therapy activities, so largely occupying the person. They weren't to stop the patient. If the patient starts to get out of bed, they could call for assistance, but that was as far as they could go. And they weren't doing any nursing care duties. It was really just having somebody with the patient and interacting with the patient. So there was, I think 34s, I can't see it on my slide there, and 10 volunteers. The volunteers provided over the period that this study went 321 hours of contact with the patient. The contact was structured between 2 and 5 each day. That was considered to be a fairly high risk time and a time that suited with the volunteer program. So it wasn't throughout the day, it wasn't structured individually to meet individual patients' high risk times, which are things you might consider if this was expanded. But it was really fairly limited. There was an average of around 10 visits per patient, and each visit was about an hour. So not a lot of time, but we looked at in terms of the number of falls that occurred while the volunteer was there in 321 hours, and there were no falls in that time. There wasn't a significant reduction in falls over when we looked at everybody over that time period and that full-time frame, not just when the volunteer was there. In terms of acceptability, there was high acceptability of the program by the key groups, the patients and carers, the volunteers and the staff. And there's some quotes there, but I won't go through those. Generally, it was a pretty well conducted program, and each of those key groups generally found it quite a positive experience. There were some issues from the volunteers. The bottom quote there was someone who felt they questioned whether they were of any value in the interaction. They weren't feeling that they were getting anything back from the patient, but I think that suggests that it might need a little bit more in terms of support and education around what you can expect. And just for being there, you may not get what we consider as normal positive feedback from the patient, but that there can be other positive outcomes from the interaction. Similarly, staff felt that it was quite valuable on a number of fronts for these patients. So the summary around that was it was a well accepted program. It potentially could reduce falls, although we really need a much bigger study and to have more of the day, perhaps targeting high risk times of day where the volunteers are available. It is a person-centred focus with respect to falls prevention. It's really putting the patient at the centre of what we're doing and trying to enhance their experience. And so that's very important as well as any outcome from a falls perspective. But it does require a bit of dedicated resources. Pulling together the volunteer people in the first place, providing the training and supporting the volunteers is a moderate role. So just need to keep that in mind if you're looking at that. So just finally, after that suite of different things that Anna conducted over a couple of years in the subacute setting, she then looked at whether that whole combination of things, when she took a 12-month period before and after, whether there was a reduction. This just shows you that the patient mix, if anything, in the second audit was substantially worse in terms of median number of comorbidities, and the number of patients on psychotropic medications was a major problem. So it wasn't that the patients would explain any difference between these two groups. The patients were actually a bit more high risk in the repeat audit. In terms of reassessments, even several years after the introduction of the Northern Health Stratify, it was still getting high levels of reassessment compared to that initial audit, and it did reduce falls. These rates are still fairly high for a subacute setting, so it's still got some way to go, but it did reduce falls by around about 5 falls per 1,000 bed days, which is a pretty substantial effect. So that we can't say which bit of what was happening. Clearly there's a lot of focus, a lot of awareness around falls. It's also going on while Anna's doing all these interventions. But that total suite of things she's done has had a significant impact over a couple of years in terms of falls in this subacute setting. And also that much higher rate of interventions being implemented where a risk factor was identified was sustained a while after that study had finished. So that's all that I wanted to talk to you about. I think it does give you a bit of a snapshot of that high level research evidence, and also a bit around some of the lower levels that might be able to give you some ideas on what might help with some of your more challenging patients. I think we are starting to get to the point where there is some reasonable evidence to guide you and to be confident that, you know, if you do put in place this range of activities, that you've got a reasonable chance of reducing falls in some of these high-risk patients. The falls risk assessment does seem to be a fairly fundamental part of what works, so having a good tool that is well accepted by staff is critical, and that follow-on in terms of reassessment and interventions being put in place. And we are starting to look at the issues around some interventions that might work with cognitively impaired patients. So I think I'll finish with that. I'll take questions if you have any questions.
Significant problem here with frequent falls. Is there anything out there that can help us aside from, you know, a total holistic assessment?
Repeat fallers, recurrent fallers are a very common problem. I don't know what your rate would be, but I think in Anna's work it was in subacute, it was around about 50% or more, and that's not uncommon. So more than 50% of people who fall once, and that should ring alarm bells for all of us and get extra things in place, hopefully, are going on to fall again in whatever your length of stay is here. So Anna's work did show that she looked at recurrent fallers, and there was also a reduction in recurrent fallers in her package. But I do think, as well as what you're doing to reduce falls generally, it's really focusing around that time of the fall and what's different at that time of the first fall that needs to be considered, and getting that reassessment. And there is a tendency for staff to perhaps think that, well, they've got dementia and they've got their old stroke and a previous hip fracture, you know, what can we do? That's what caused the fall. And we've done a bit of work which has looked at what staff perceive as the causes of falls, and they very commonly just look at what are the chronic problems that the person came in with, without thinking about specifically any new problems or the environment. And I do think the environment's a fairly major issue as well. So I don't have a simple answer, but I think it's a very strong review. Some groups have used, particularly in residential care, but also a bit in hospitals, a post-fall consultation. So when a fall occurs, particularly one that's not clearly what are the reasons for this, that you might have one or two members of a falls team come and do a bit more of a detailed look rather than just rely on the risk assessment and see where there's something else that could be done. If it's a cognitively impaired patient, which a lot of the falls do tend to be, perhaps some input from someone with cognitive impairment specialisation.
Thank you very much. Just some things to go on.
Okay, thinking about recognition and management of delirium in terms of falls, I mean, one of the things that we find here at Charlotte is a lot of our incidents that a lot of the patients have got delirium which has gone unrecognised. Was that any component of making from Cochrane or from the HD study?
Off the top of my head, I don't think delirium by itself has been addressed in any of these interventions in the Cochrane review. There's certainly evidence that delirium is very poorly recognised and very poorly managed if it is recognised in hospitals, and it's quite common, and people do tend to describe it as a cognitive impairment and think of it as a permanent impairment. So there's a lot of work that needs to be done there, and there is a randomised controlled trial evidence not looking at falls as an outcome but looking at delirium identification and management that has shown that a program put in place, the author of that work is named Inouye, I think, Inouye, and that you can put in place a program in a hospital, in acute hospital setting, and substantially improve your recognition and management. Hasn't been shown then to go on to reduce falls, but one would expect that that would be a likely outcome, as well as clearly the whole range of other benefits of recognising and treating the delirium.
Thank you very much. Can I just say before you all rush out, it's national standards, you've all heard about them. I need to make sure that you've signed in. And also, can you fill out your feedback? That's very helpful to keep as well as we go. Thank you very much indeed, and thank you.